So this is diabetes in children. And let's first just make sure we're talking about the same things. We've got type 1 and type 2 primarily. Type 1 is a deficiency of insulin secretion, and this is because those beta cells in the pancreas have been damaged, so they cannot make insulin. There's not enough insulin, or probably there is no insulin, because the beta cells are all dead. Type 2, on the other hand, we have our biggest issue is insulin resistance. Cells need to grab hold of insulin in order to get in sugar. It's like they have to make a little chain. Sugar can't get in unless you have on the cell membrane, unless it first grabs the insulin and the insulin grabs the sugar. Well, those receptors on the cell membrane just sort of get lazy, and they don't reach out and grab the insulin. They kind of just let it float by and don't really care. So that's insulin resistance. And this happens everywhere. Skeletal muscles, liver, adipose tissues. And then you can have some of that beta cell damage, but to varying degrees. Probably the beta cell damage is going to be mild to moderate, where in type 1 it's going to be severe. And a lot of times that beta cell problem, it can't make enough because of obesity, because the body's so large. Where type 1, it has nothing to do with obesity. There are a few conditions that put a child into diabetes mellitus. Cystic fibrosis is one. Over time, the pancreas gets damaged to the point that those beta cells get destroyed and they become a type 1 diabetic. And some studies are saying up to 50% of children with cystic fibrosis will become type 1 diabetics. And then glucocorticoid use, which this is, when we have kids on steroids, it increases their blood sugar. So things like Cushing syndrome happen where they have a high blood sugar. This is like being a type 2 diabetic. They do make some insulin, but not enough, and the cells are not very anxious to grab the insulin and use it. And then certain genetic syndromes put the child at a much higher risk than the average child for developing diabetes, things like Down syndrome. So here's just a little chart, that type 1 versus type 2. Type 2, there's a definite family history. Type 1, usually not. There are some exceptions to that where everybody in the family develops type 1 diabetes, but in general, it's not. Type 2, certain ethnic groups have a higher risk. Not true with type 1. The polys, right? Polyuria, polyphagia, polydipsia. You definitely will see those in type 1 diabetes. And in fact, that's often the parent and child's complaint, is that they're peeing all the time and drinking all the time, and they're hungry all the time, and they are losing weight. And they put weight loss as possible. I would say it's far more than possible. It's most of the time. And that weight loss is primarily from dehydration, because they go into DKA. With type 2, you can see those polys. Their weight, they're usually obese, and you don't really see a change in the weight based on how their blood sugars are doing. Onset, type 1 is younger, type 2 is older, although that's not an absolute. Type 1, usually the child goes in with complaints that they're peeing, they're thirsty, they're getting dehydrated from all the peeing they're doing. And so that's how they find it. Where type 2, usually it's just an incidental finding, that you go in for something else and they check your blood sugar and then diagnose you. A flu-like illness beforehand, that's usually what is common in type 1. The child was ill before, and then it seems to be that it's kind of an autoimmune response after that viral illness. You might have that in type 2, you might not. And I said autoimmune, right? So if we look for autoimmune antibodies, yes for type 1 and no for type 2. Diabetic ketoacidosis. This is a life-threatening complication of diabetes. It's possible but not common in type 2. It is very common in type 1. And in fact, a newly diagnosed type 1 diabetic, you should assume is in diabetic ketoacidosis because most likely they are, and it's safer to assume they are than just kind of say, well, they could be. So common, and anytime they have an illness or somehow their blood sugars get out of whack, they can and will go into DKA much more quickly and easily than type 2. Things like hypertension, the lines that you get, which kind of go along with being obese, and lipids, too high of lipids. You don't see any of that with type 1. You see it with type 2. So I kept saying ketoacidosis is an issue with type 1. So what is that? That is when cells don't get glucose from metabolism, so they start using other sources, particularly fats and proteins. And the waste products from breaking those down are ketones. And ketones are extremely acidic. So ketones are the waste product. You end up with excess ketones, which the body tries to get rid of in the urine. So you get that ketone urea, and the acid is trying to blow it off with the lungs, so you get that acetone breath. As I said, ketones are a strong acid, and if you remember, your pH is your hydrogen ion, and it's an inverse. So the more of it, the more free hydrogen ion, the lower the pH will be. So you get a significantly decreased pH on your blood gas when you're in ketoacidosis, diabetic ketoacidosis. This has progressive deterioration from dehydration. The body's trying to get rid of that sugar and that acid through the urine, so they pee excessively. Where all that extra hydrogen ion, right, if you think about that, that's a cation. It's going to throw off your other electrolytes. And the biggest one it throws off is potassium, because that's also a cation. So you get a significant electrolyte imbalance. Sometimes on the lab work, the electrolytes don't look that bad, but intracellularly, right, when we do labs, we're looking at the serum of the blood outside, or the fluid outside the cells. Inside the cells, the electrolytes are worse because that sodium-potassium pump gets goofed up from all that extra hydrogen ion. The hydrogen ion goes inside the cells, knocks the potassium out. So your serum may not look as bad as the reality is. And acidosis, that electrolyte imbalance and acidosis kind of go together. This can lead to coma and death. And probably the worst thing you can do for a child who's in diabetic ketoacidosis, their blood sugars can be high, right? But probably the worst thing you can do is give them insulin. You have to correct the electrolyte imbalance and the dehydration at the same time as bringing down the glucose slowly. You just give them a big dose of insulin without correcting the electrolytes. You can give them a cardiac arrest. So diabetic ketoacidosis is very serious. It should be managed in the ICU. So what do you see? Nausea, vomiting, fatigue, weight loss. That weight loss is from dehydration. Hunger, increased urination, drowsiness, thirst, abdominal pain. They just sort of feel crummy because their cells are actually inside the cells. They're acting like they're in starvation mode because they can't get sugar. So our goals of management with diabetes mellitus, we're talking about kids. Most of the time they're, pre-puberty when they're diagnosed with this. So we want them to have normal growth and development. They're going to have a chronic illness they've got to take care of. but we don't want them to become sickly children or children who don't fit in with feel like they don't fit in because of this. So part of that is getting good control, good glycemic control for them. So we want fluid and electrolyte levels, normal, hemoglobin A1C, close to normal, and often till we know how they're going to do. We kind of start at a little bit higher level till we bring it down to where we know they're going to be able to maintain. We do want to prevent those complications that you think of when you think of the diabetes. Vision loss, kidney damage, the neuropathy, cardiovascular disease, all those things. Those come from high blood sugar over a long time. And as long as we control these kids, we can avoid most of those things. And then we want to promote positive adjustment to the disease. They're going to have to live with this forever. We want them doing self-management. And what we've really gone to with kids is, rather than saying you can never have anything with sugar in it ever again, is we're trying to be a little more normal. You go to a birthday party, you want cake and ice cream with everybody else, so you need a little extra insulin to do that. So back to DKA, should be in the ICU the first 24 to 48 hours. The first thing you do is a fluid bolus. They come in profoundly dehydrated, typically. And so that high blood sugar, part of that's just it's concentrated because there's no water in their serum, so there's way more of everything. It's just concentrated, that hyperosmolarity of the blood. So first we're going to give a fluid bolus. Then we can tell better where the blood sugar really is, where the electrolytes really are, and where the pH really is. And so we've got to correct all of those things kind of simultaneously. Electrolyte replacement, they usually need a lot of potassium, but not a lot of chloride, because they have the chloride that was connected to the hydrogen. Right? So we're going to correct that acidosis using IV solutions that have a buffer in them. And often K-acetate would be a possible choice they might order. We're going to put them on a continuous IV infusion. So we're not going to give a sub-Q dose of insulin. We're going to give a little bit continuous by IV. So as it's coming down, when they get to a certain level, they're actually going to add blood sugar into the IV solution and try and get to a point where we're kind of giving them sugar and insulin at the same time until we get it down to where we want. And they're not going to try and get it down to 100 that first day. They're going to be shooting for higher than that, because if you remember, you will die fast from too much insulin and very slowly from too little. So there are other complications that they're worried about as well. So it's correcting everything simultaneously and fairly slowly when you're in DKA. So the different types of insulin, when we have them on that IV insulin, we usually are using regular, which is our short acting. We can also use our rapid acting. But just kind of to review these, right, we have rapid acting. These start working within 15 minutes. The peak is about a half an hour after giving it. We don't give this until the person's food tray is in front of them. And in fact, we love this with kids because they can look at the food tray and say, I'm going to eat that and that, but not that. And so we give them the exact amount based on what they're going to eat. The short-acting regular takes 30 to 60 minutes to start working. Its peak is about 2 hours, so that's why we give it at whatever, 6:30 or 7 for breakfast at 8. Intermediate, our NPH, takes 1 to 3 hours before it even starts. Its peak effect is about 4 hours later, right? So we give it in the morning, and it covers you at lunch. Long-acting, takes an hour or two to start working. There's not a clear peak, but it can last for up to 24 hours. So